8 minutes to present. Once you present your data, we'll discuss next 2 minutes. Sergi, you can ask questions 2 minutes, and the house also can respond depending on their interest and the subject. 8 plus 2, sir. So 10 minutes you get. It's okay. So 10 minutes you will get, out of which 8. If you present early, you get more time for question answers. And based on your matter of presentation, the way you discuss, the way you present, everything will be counted. The way you stand, your manners, everything will be counted so far as the marks are concerned. And wish you all the best. There are 3 prizes, the first and the second and the third. These are the cash prizes, and that will be distributed, that will be given to you during the keynote address in the main hall, Hall A. So wish you all the best once again, and we'll start the session. Sergi, any words from you?
So you invite the first.
Okay. So the first person is Viral. Viral, you have your presentation.
Good morning, respected chairperson and my colleagues. I am Dr. Viral Sagwan. I am an associate professor in heading one of the unit in PGIMS Rohtak. My field is critical care. I am DM in critical care, but I am heading medicine unit also. So this is an interesting case, insuloma presenting as a neuropsychiatric symptom and unusual presentation. Pancreatic endocrine tumor are rare lesion, 4 cases per 1 million patient. Insuloma is the most common pancreatic endocrine tumor. Majority of the patients were between 30 to 60 years and 60% in women. Insuloma causes fasting hypoglycemia due to excessive secretions of insulin. May present with neuropsychiatric symptom and may wrongly treated as a neuropsychiatric illness. So this was the patient who reported in our OPD many times to our resident, a 55-year female complaining of altered behavior and decreased sensorium off and on since 2 years. And when she presented in the casualty, her blood glucose was 36 milligram per deciliter. After glucose infusion, 100 ml of 25%, she regained consciousness. There was a history of altered behavior off and on since 2 years, and she was taking antipsychotic treatment from a private practitioner from the same city, Rohtak. Associated symptoms also there: tremors, anxiety, palpitation, and diaphoresis. Symptoms mainly occurred in prolonged fasting stage. These symptoms improved after eating some sweets. She noticed also weight gain of 7 to 8 kg since her illness. And there is no history suggestive of insulin or oral OHA intake, no history of chest pain, dyspnea, involuntary movement of body, frothing from mouth, tongue bite, urinary incontinence, galactorrhea, renal calculi, jaundice, or facial puffiness. Her pulse was 114 per minute and BP was 134/86 in right arm supine position, millimeter of mercury. Lab investigation which was done when she was admitted in our ward, blood glucose was less than 40. So we carry out this, all these investigation. Insulin level come out to be 14 micro per ml. For insuloma, it should be greater than 3 micro per ml at the time of hypoglycemia. And C-peptide come out to be 3.88 nanogram per ml. For insuloma, it should be greater than 0.6 nanogram per ml at the time of hypoglycemia. Insulin antibody were normal, that was 4.32 units per ml. TSH and insulin IGF-1 and insulin-like growth factor, BP3 levels all were normal. Serum cortisol was also done, but that was 12.89, that was normal. Ultrasound abdomen, no abnormality. CT also had no abnormality. MRI abdomen, no pancreatic abnormality. But we carry out then PET CT abdomen of abdomen and pelvis. It show area of focal increased tracer uptake in the region of body and tail of pancreas, size of 2 into 1.1 centimeter. We carry out the management, we stabilize the patient, then do surgical removal through segmental resection was done, and patient maintained blood glucose normal level after the surgery, and now she is asymptomatic. This is the biopsy tissue, surgically removed tumor specimen showing tumor of pancreas. And this was the pathological slides showing uniform cuboidal cell with centrally located nuclei and acidophilic finely granular cytoplasm. So stroma is highly vascular and abundant hyaline materials separate the tumor cell into scattered nest. Coming to discussion, Hypoglycemia is defined by Whipple's criteria consisting of CNS symptoms like neuroglycopenia. Simultaneously, there is low blood glucose and improvement of these symptoms by intake of glucose. Most common causes are drugs, OH, mainly insulin and insulin secretagogues. Other causes can be alcohol, severe liver and kidney disease, starvation. Hypoglycemia due to hyperinsulinism is found with insulinoma, insulin hyperplasia, and insulin autoimmune hypoglycemia. Signs symptoms are like diaphoresis, warmth, hunger, weakness, tingling sensation, paresthesia, difficulty in thinking, confusion, shaking, tiredness, drowsiness, palpitation, faintness, dizziness, anxiety, difficulty in speaking, sometimes blurring of vision, can have seizure, and if blood glucose can go very low, then can have coma, stupor and coma. Coming to conclusion, misdiagnosis of insulinoma is very common. There are some case report of insulinoma who present with behavioral abnormalities and psychiatric manifestation. Like this patient who was on follow-up private practitioner since 2 years, and she was on antipsychotic treatment because of his symptoms, but cause was the insulinoma. Yes, around 7 to 8 kgs.
She's gained
Yeah,
7 kg, 8 kg. Did you check the sulfonylurea levels in this patient when patient was in fasting hypoglycemia?
No, sir, it is not available in the hospital. So only the investigation which were
Don't
available.
you think it is important to differentiate between, say, patient is on fictitious sulfonylurea, patient is not a diabetic.
Yes.
If patient is on sulfonylurea, will have high C-peptide, high even insulin levels,
Yes,
and low fasting sugar. So the fourth component, important component, is to look for sulfonylurea levels and maybe even pro-insulin levels also.
Yes. So it's important.
That is the only way you will differentiate it from a sulfonylurea, fictitious sulfonylurea induced
We take a
hypoglycemia.
history from her. She denied she not on any
Young
OHs.
patient, young females, it is very, very common cause, especially females who are from a family where there are a lot of diabetics. They come to know that moment you take this drug, there is an overdose, patient might dip into hypoglycemia. So many of the functional females or those who have psychiatric illness, they consume high doses sulfonylurea in between to induce hypoglycemia. She went to psychiatrist.
Since she was
Yeah.
on follow-ups in 2 years. Yeah, now after surgical, no, she is on follow-up. It's normal.
She responded to only dextrose or you had to give glucagon or something?
No, sir, only 100 ml, 25% infusion. Then till PET CT was done, and it came out to be in body, body and tail of pancreas, there is a mass. And
Once
then
you do even simple ultrasound or a PET or maybe CT,
But it was not,
it is
by
almost
chance it was not picked up on ultrasound.
almost.
Because only resident
It's a typical case of insulinoma.
Yes.
There's no doubt on
men syndrome.
men
yes,
syndrome.
yes.
Yeah, you look for other things.
CT I had was done, that was normal. MRI, TSH, yeah, serum cortisol level, that was also normal.
You know what is MEN1 or MEN1?
Men one, MEN,
What is the various involvement in MEN1?
pituitary, parathyroid, and
Parathyroid,
pancreatic
pancreatic.
insulinoma. Yeah, they're classical, but they may be part of the syndrome with many more endocrinopathies. Yeah, many more tumors. But classical one are parathyroid, pituitary, and
Pancreas.
pancreas. Yeah. It is common. Yeah.
She is on follow-up now. We will do investigation.
Anybody has seen a patient in insulinoma? Anybody has seen, heard of insulinoma, but not seen?
I have a presentation today in the afternoon on non-diabetic hyperglycemia. So if you are there, come there.
Yes, sir. I will come.
Many more causes will be enumerated other than men.
No, I presented a patient with hydroxycosis with hypoglycemia. That did.
Okay, well done. Thank you. Pardon?
Insulin levels should have been very high.
But it was much more than the cutoff. But normally I agree, levels are extremely high, C-peptide is extremely high. They haven't looked for pro-insulin, which is almost diagnostic. And if you perform, did you perform 72-hour fasting test in this patient? You admit
No.
the patient?
Yes, sir. We give him infusion of 25% glucose, and carry out all the, but not fasting.
Classical is a 72-hour fasting
Yes.
test to differentiate whether it is insulin induced or sulfonylurea induced or insulinoma or anything of men or maybe something like non-secreting tumors versus sulfonylurea fictitious hypoglycemia, exogenous insulin, which may be used in even in non-diabetic persons.
Yes.
They may inject themselves insulin and many more drugs. So that is actually a classically 72-hour fasting test you perform and look for everything. C-peptide, pro-insulin, then of course insulin level and try to titrate, plot it against the sugar levels to find out what are the exact values.
Yes.
But because you probably had picked up on CT or on,
Yes, sir.
so you didn't investigate further. But that is a classical test to differentiate various
We
types.
carry out C-peptide and insulin level that, then we have suspicion it may be insulinoma, and then we carry out that PET CT abdomen.
We had recently gone for the ACE meeting. Dr. Bridgemaker also was there. They were presenting about the insulin signaling pathway, and they were requesting that patients of insulinoma can be sent to them because they want to know how these beta cells survive in this medium, and they want to study this to understand further for the beta cell transplant and so on. So they made a request to all the delegates, those who see patients with insulinoma. I hope you were there in that hall some other place, yeah. So there's an ACE meeting which had in Boston. There's everything on the online. You meet them, just write to them that you have a patient with insulinoma. If they want to study this patient, then you can send it free of charge.
Okay.
Okay. So very good, well done.
Thank you. Yes, sir. I am under Dr. Sameer. Now Sameer have resigned, so I am heading the unit. Yes.
Ajay Rohtak.
I am under Dr. Dhruv Chaudhary. I am under critical care. My field is critical care. But I am heading medicine unit also, sir.
Okay, good, good.
Thank you, sir. Thank you very much.